And shout the question out really loud, because I won't be able to repeat it.
Okay. My question is, a couple of weeks ago I saw on the Sky news feed there was an article about women trying to get the TVT banned because of chronic pelvic pain. I understand there was a reply last week on the BBC newsreel saying that actually that was quite a severe reaction. Anecdotally, I have patients who've had TVT operations for incontinence who have maybe had to have them removed or divided, but anecdotally I have found clinically there has been a huge issue of chronic pain, and I just wanted to ask your opinion, what you've heard, read, or anything that you're advising patients regarding the procedure currently.
I think that one of the issues is that we might not get to see these patients, because I think that it is an issue for some women, but I believe that the risk of having anything go wrong is minimal. It's less than 5%. And I think in terms of advising them, then it's just you've got to look at the benefits and the risk and weigh that up to how bad their incontinence is. I certainly haven't seen very many with terrible pain problems. I think it is an extreme reaction to want it banned. On the other level, our follow-up on it is only, 15 years at the moment, I think, max. So it's quite short, and you know, really you need a much longer period of time before you can say, well, this is really uber safe to use. That would be my opinion.
Thank you.
We see quite a lot in the pain clinic, but we have a slightly different cohort to what you're seeing, and we often have people who've had pain for quite a long time. Increasingly, we advise people if the pain comes on immediately after it's been put in, it should come straight back out again. And increasingly that message is feeding through to the urogynecologists who bring them in. And that's sort of being led largely by Susie L. Neal's group in UCL. So we do see that. We also see it with other mesh, so other pelvic floor mesh repairs. If they're in agony afterwards, it should just come back out again.
Dee, shout it out.
I'm just wondering about how much you use your e-stim over here for the neuromodulation properties with pelvic pain or vaginal pain.
I'll take that one since I talked about STEM. Not very much at all, really. It's usually, I think one of our issues around the incontinence, most of the women's health videos are guided by NICE not to use stimulation as a first-line treatment, but to only use it when somebody has difficulty contracting, which in a previous guideline said a grade 0 to 2 on the modified Oxford scale. So we've been quite blinkered and quite narrowed as to the use of it. There are, on a lot of the commercial units, they have pain programs, but I don't see it in clinical practice being widely used, and I think we're missing quite the trick by not using it in that sense.
I've never used it at all. So I don't know, I will be thinking about it, but I just don't use it at all. I haven't felt the need to use it, but I'm not saying that perhaps somebody could get there quicker if we did, but it would be really interesting to
I've used neuromodulation with certain patients, and it seems to be, you know, it's something, it's an adjunct to everything else that we're doing, with the theory that if you bombard them with enough interventions, you build it up over time, then you're going to make those differences in the pain response. So yes, I've had some success with it.
Brilliant. Maria?
And Julie, just to finish on the electrotherapy, I was thinking, you know, if you've got asymmetry, so say the left side is soft and bulky and normal function, and the right you might have a later anal avulsion or something like that. So there's no pain, was there, and you still want to strengthen it. Is it safe to use the units if you find that asymmetry?
Yes. I think the problem will be the fit of the electrode, because obviously the circuit that you're trying to make, if you've got asymmetry and you've got a rigid electrode, if it's not big enough, it's not going to then, it will try and angle itself. You know, things don't quite work in the way we think they work, but you just need to make sure that you've actually got good contact, and I think it's even more important with those women to make sure that the electrode type is fitting them and that you're getting the effect that you want to get.
Can you steer the stimulation from one side or the other?
In theory you can. There are electrodes where, one of the gold ones that I showed you, you can get them with the knobs just on one side. Yeah. So in clinic you could actually hold it in place, or you could teach the patient to do that themselves. and just stimulate on one side. In theory, that's said, but actually what we don't understand, and we're just about to launch on some research work with one of the Scottish universities, to actually try and track where the circuit actually goes, because although I drew that nice line diagram, that's textbook, but actually we've been challenged by a professor at Strathclyde University to go, is that really where you think the current goes? Because it's going to take the route of shortest impedance or lowest impedance, so it could well be just zooming around the top of the electrode and we know we're getting contraction, but we don't actually know where the current goes. So if we stimulate on one side, it's probably wandering around all over in the pelvic floor anyway. So I think using a bilateral electrode is probably just as good as anything else for now. But we'll know a bit more next year, hopefully.
Okay, Angie?
Julie, you said about when you're using muscle stims, some people have a rest day in between, and I was just thinking about extrapolating this onto exercise and rehabilitation of the pelvic floor. Would you advocate, or I don't know how the panel feels about exercising on alternate days rather than the 3 times every day that we always say? Do you have any feelings on that?
Well, I don't think any of us know the answer to that question.
Exactly. That's why I just
keep my mouth shut. I keep all this way.
Yeah. You know, earlier on we were talking about how little we know, that we've just scratched the surface. And we don't know, we haven't got a prescription, but there's nothing standardised for anything very much in the pelvic floor arena. And so I think it's just trial and error, really. I mean, the workouts that we do are generally quite short, aren't they? We do intense, high-intensity workouts, maybe 3 times a day. I would suspect that in most cases the muscle is sufficiently recovered by the following day.
Yeah.
To do them every day.
And just on from that, is there any absolute evidence that you know of in favour of what people call the toner, the half hold of 30% in the pelvic floor, functionally? Is there any evidence that actually...
No, I mean, I use it clinically, and I get clinical results, but it's one of those arenas where I don't know that it's that sexy enough for somebody to go off and do their masters and look and produce a piece of research. But I think most of us would sort of go along with doing that sub-maximal.
Yeah, sub-maximal and maximum, you know, to do the combination, particularly what's important in driving it for that particular patient. If they've got decent endurance but they haven't got strength, you know, bias it that way, and then obviously the other way around as well. But functional integration, you know, timing function, stuff like that's really important, and getting the right direction if they're stress incontinence and stuff like that, you know, because it's no point in having a really strong contraction if it doesn't go to where you need it to get to.
If you wanted to get fit, would you do a high intensity workout 3 times a day, or would you maybe start with every other day?
Yeah, exactly.
Yeah. I think functional.
Depends on your starting point, doesn't it?
Yeah. And I think the other thing to think about is a bit like the stim and going to tetanic level. We don't function day by day in our normal lives. We've got working maximally. We grade it according to the needs, and I think that's what we should be thinking about with exercise prescription as well.
Okay, Isla?
I was going to add to that, we're working exercise in sports science. This is where we need to be joining forces with the muscle conditioning. I'm sitting here note, but we're talking about recovery, particularly from maximal volume to contractional spinal research, so let's get together.
Yeah, brilliant.
Can I ask something?
Sure, shout it out and say who you are and where you're from.
Hi, I'm Liesel. I'm women's health basically. At Pittsburgh City Hospital, but starting to see some males, so I've got a male question if that's okay. I have a patient with left-sided testicular pain, but most of the pain is, he explains that after he's driven home after work, there's a feeling of the testicle actually rising. So I've done a lot of work with him, so I've worked a lot lumbar, which actually has made a difference, and then I've worked a lot internal as well. It was my first one, so I was quite sort of in the woods there, but yeah, I think I would have. And then, it was actually after your course, Ruth, so thank you. But anyway, I think I'm sort of at the point they've sent him to me, I think it's the last resort. But I do think I'm probably looking at a retracting testicle in some degree. So I'm just wondering, am I going to get all the way with this guy if the testicle actually is lifting only on the one side? Because he physically says it's higher once he gets home, but then drops as he sort of relaxes. The problem started after he was a truck driver. So probably posture sort of pedal-wise, I think there must have been something. So I do think there's an element of pelvic floor, because also his anal squeeze isn't great. His squeeze is absolutely anterior. We've got very little anal activity. Defecation isn't great either, so I'm working on that. But I just want to know, should I ask again for further input, or do I just continue with what I'm doing?
So, brilliant that you're doing it. Well done you, because it's sweet, really. So there's a couple of things. It sounds like you've still got overactivity, and with an anal squeeze thing, it might be because, again, he's like that already. And the fact that it's one-sided is classic, one-sided particularly working. The other fact that because his hips are probably part of the equation, so evaluate the hip stuff as well, especially because of the driving thing and things like that as well. And because obturator internus, which is one of the deep hip muscles, classically refers to the testicle, that fits in beautifully, so from a mechanical perspective as well. So again, keep with the down training, check out his hip stuff. If you're not happy about checking out the hip stuff, get somebody in
But
to...
actually, he had very limited hip range of movement in most ranges, so I
Yeah,
did loads of stretches, which
yeah,
actually is
that's it.
changing.
Yeah.
The other thing is I've worked a lot on the abdominal fascia, which
Yeah.
I've given him home, and actually that's making a difference. So the pain, where it was a constant 2 out of 10, but for years, is now an intermittent cycle.
Brilliant.
So we're getting there.
You
but
are.
I'm just sort of like, I don't know how long I should continue.
How long have you been treating him? Is this all right to keep chatting?
Probably about, I'd say about 3 or 4 months now.
Oh, that's sweet.
So actually, it's not that long.
No, it isn't. It isn't, because you get motor control changes very quickly, right? 3 months approximately, you get actual muscle fibre changes going on. The fact that he's had it for how long?
Over 10 years.
Exactly, girl. You've got to be desensitising the stuff as well. So that sounds really that you're doing a brilliant job. Okay? So and the other last thing about that, did you get him to fill in the NIH questionnaire?
No, I didn't.
Okay. Everybody who does anything, honestly, because it's an objective measure, right? And often the urological symptoms will change before the pain stuff does. So if they're feeling a little bit, it's not making much difference. Often when they fill that in, because the questionnaires just change over time, that's really good. But you sound like you're completely on the right journey. Well done.
Would he be open to psychological intervention?
I think he might actually, because he's starting to be a bit more open now. I think we're sort of building a relationship.
Yeah.
I think in terms of trust. So at first he was a bit not that much forthcoming in terms of sexual things.
Yeah.
Like that. But his wife just had a baby, so intercourse doesn't happen as often. But he does mention that there's pain elements to it and discomfort.
Yeah, I mean, what we see in our clinics is that they have this very fixed context about the one thing that produces their pain, which in your case is driving.
Yes.
And then the guy I saw last week with the same sort of pain was having sex. But actually, when you take a detailed history, it's happening during all of the things that are using pelvic floor muscles. And then they need to unpin some of the context clues that they're getting. So when they're sitting in their car, they're expecting to be sore, so they're getting tense as they're sitting there. All right. And psychology can help with that, but only if, in the same way with physio, they have to be able to engage with.
I think with us, it's the availability of it. We don't have it at the hospital, not for men as far as I'm aware.
Yeah, and you probably won't have a psychologist who wants to deal with sex taboo.
No, and I mean there's a sexual health centre, and I think they do counselling, but it's private and it's quite expensive. And I don't know what sort of input you would have from there. But I mean, I could always talk to the GP to see if there's something available that they'd be happy to fund.
Yeah.
Because he's been through all the tests, urology-wise, and there's just nothing.
Exactly, and that's
but there
why...
obviously is something. So I'm glad that he came to us. But
The pain service at Leicester has psychology input for pelvic pain, although they have traditionally mostly seen women. And I think there's a guy called Andrew Ravenscroft who works at City Hospital in Nottingham who sees a lot of men with
because I've got
pelvic pain.
another female patient that's under him.
Yeah.
Brilliant. Thank you very much for that. I'm sure that's something that you'll continue to chat about at Herbert. Maria?
I have one quick one to William. For the postnatal moms that come to the clinic who can't sit, what do you do for those? Or I know you used to work at Queen Square with Baranowski.
Yeah.
Do you do the blocks, or what would you screen them for if they came in, 3 months later saying, so it's delivery. I can do most things, but I can't sit.
Yeah, so in the medical clinic we screen them for most of the things that are associated with pain. So we spend a lot of time looking at the pain history and whether there are any suggestion of things that medical things, and usually there aren't. And then we spend a bit of time looking at nerve issues like pudendal neuralgia and ilioinguinal neuralgia and all these sorts of things, because patients expect to have that, or they always think that they've got pudendal neuralgia, but in fact we see that very rarely. We sometimes do blocks. I'd say we do blocks. Our colleagues do blocks more often in the private sector because there is a billing component to that that makes that a favourable treatment pathway. But I quite often do blocks even in the NHS to reassure somebody that that isn't the cause of their pain and that then they can move on. And I did a talk to GPs in Birmingham about a month ago, and I only talked about 2 conditions. I talked about pudendal neuralgia because everyone thinks they've got it, and I talked about pelvic floor dysfunction because everybody has it, but they don't think they've got it.
Anyone else like to ask a question?
Can I ask just
Hi.
another question?
And just shout out to the people at the back as well.
When would we refer into your clinic? At what stage?
Whenever you like. Really. The difficulty is finding a clinic that deals with it. Do you work in Northern Ireland?
No, Staffordshire.
Oh, you're all right.
But, well,
Because we used to, when I worked in London, we used to see a lot of people from Northern Ireland because there isn't anyone who does it in Northern Ireland. But clinics are pretty few and far between for pelvic pain. When the pelvic pain specialists get together in the UK, there are fewer than 20 of us probably. And some of us are doing services for women only, and some of us are doing services for men only, and not very many of us are doing services for both. From Staffordshire, you could refer down to Birmingham. There was a guy called Winston de Mello who's doing some stuff in South Manchester, but he has recently gone off the radar for reasons unknown. And then there are services in Leicester, which are reasonably convenient for Staffordshire patients as well. But we're happy to see patients just whenever. We really are signposting people to other places. We will do the blocks for them if that's a hurdle that they need to get past to reassure themselves that that isn't what they've got. We can look at their other pain. The biggest problem for me is then having people that I can then signpost them out to, and finding physios in the Birmingham metropolitan area or even the West Midlands area who do pelvic pain for men and or women, either in the NHS or in the private sector, has been very, very difficult.
will you take referrals from physios?
Um,
Or does it have to be GPs?
From my own point of view, I'm not fussed.
Okay.
But I think the hospital get a bit upset because there's some way of clawing back the tariff. And in the same way that we have to refer to other NHS physios via the patient's GP, it's probably easier to go that way. Often the GPs haven't referred because they don't know that there's a service available. In the same way that people won't refer to you if they don't know that you're doing what you're doing.
I've just got one question myself, and it links to what William has just said about these psychological interventions and some of Richard's work on cognitive behavioural therapy. Is how big a part do those cognitive behavioural emotional factors play, particularly in the chronic pelvic pain, but also the pelvic floor dysfunction? And what big key strategies do you tend to use clinically?
Your turn.
My turn. I think it's absolutely massive. It's absolutely massive. The thing is, as I said on my slides, just talking about the fact that most of them think they've got pudendal neuralgia, and I genuinely have treated 3 or 4 people who've got pudendal neuralgia, and it can change with physical therapy as well, right? So, using CBT approaches, I tend to get them into the meditation aspect, because again, quietening it down that way is really, really, really helpful, okay? Because I don't have at the moment, people that I can easily refer off to, but there's also some brilliant books like My Body Spirit Workbook and things like that, which actually can get writing down the stuff, because as I said to the psychologists who were writing in our book, you know, what exercises do you prescribe if somebody can't go to see a psychologist? And they say about writing stuff down, reading it back to yourself, so at least you're sharing it with somebody. So I think it's the mindfulness aspect of things is really, really, really important. And as I said to my patients, I said, do the same thing twice without any significant increase in dysfunction, and then keep just building it up. So if you anticipate pain, you are going to get it. So therefore, you start at a level that you don't think is going to hurt you. And that's how I basically build it in. So I'm trying to get them to just keep gently challenging themselves, so they are in control of it still. And that's, I think,
Brilliant, thank you. Sorry, Richard, we'll take one final question, and Richard, who's a clinical psychologist.
I just wanted to pick up on that really in terms of linking what you just said there about mindfulness and what you were saying earlier about threat.
yes.
There's a recent study on mindfulness that just 10 minutes of mindfulness practice a day reduces both the size and the activity of your amygdala, which is a threat centre in your brain, so that there's a clear link between people who have a mindfulness practice and why their anxiety reduces.
It's
Yeah.
magic. Thank you for that.
Yeah,
Can I
yeah.
have a reference later?
Yeah.
The only thing I would add to that, I mean, the most commonly held or accepted definitions of pain include a significant emotional component. So everybody who has pain has a psychological component, and the longer you have it, probably the greater the psychological component. The difficulty is getting people to engage with psychology, because they see it as psychiatry, or that it's a way that the doctor's now saying, oh, it's all in your head, so go and see the crazy person. There is quite good evidence that psychological therapies delivered by physiotherapy or by nurses or by other allied health groups is as effective, and that is really important for us because that overcomes the biggest barrier. The biggest barrier is seeing the person, then have the same therapy from the physio, and that is a good way of getting acceptance.
Do you have a reference for that?
No, but I can get it for you.
That'd be good.
And I would like to... Okay, one last question, sorry.
My name's Sandra, I'm from Woking.
And just shout the question out for those guys.
Yeah, just we work within limits of having maybe 4 sessions with a patient. Can you give us some guidelines on how you manage all of these things that we've been talking about today?
There is no way you can do it in 4 sessions, and I think you need to talk to your trust and go, in order to deliver an effective intervention, there is no way you can do it in 4 sessions. The only time I've ever done stuff in 3 or 4 sessions is if I have an acute, somebody actually gets to see me rather than waiting 7 years to be able to get to see somebody like us that do this stuff. Is I only had the problem for 3 or 4 months. And yeah, just when I like having a knee injury, job done, tick. And that's basically what I think. I also think potentially developing a support group, within the hospital, so that you've actually got lots of people who've got the problem, actually, so that actually having those sort of sessions as well might be an adjunct. But there is no way, like even the research that, I pulled a little bit of holes in, right? That was 10 sessions, right? And so again, that gives you evidence, even though don't tell them about the holes in it, it gives you evidence that actually 10 sessions.
Yeah. Most pain management programs are at least 8.
Yeah.
Brilliant. That was amazing, 25 minutes. Big thank you to Kay, to William for coming along, to Ruth and to Judith. Don't move for a second. So we will have lunch now, and then we start back at... Anyone got a program now? Sorry? 1:40, perfect. And so enjoy lunch, and thank you very much. Thank you, it's just wonderful.